everyone. It's Dr. Koivusalo.
Great, thank you. I come from Helsinki. Our hospital is the main tertiary referral center in Finland, big hospital in Scandinavia, small hospital in Europe. And my case is of the boy who had esophageal atresia. Now here we have on the left primary X-ray from this boy. You see that there is an esophageal atresia. The nasogastric tube is making a curl in the upper esophageal pouch, and there is no air in the abdominal cavity in the bowels, so it means that it's without a fistula. So we started the standard treatment, giving him a gastrostomy and suction of the upper pouch of saliva. And in 6 weeks we did this examination. We put a scope in the upper pouch and scope through the gastrostomy in the lower pouch. And then we can count that the distance between the end of the scope is about 6 vertebrae, so it means that we can't do a primary anastomosis there. And in this, so we have several options. Nowadays we use this. We put bridge the pouches with a jejunal, with a graft with the pedicle, which is some kind of construction is there. And so far so good. There's an X-ray on the right, except on the day 4 after the operation. You see that the contrast is going to the thorax and partially to the abdomen. So we had a leakage of the anastomosis. So this boy is quite fragile with a Down syndrome and a heart condition. So we decided on constructive treatment of this leakage. And we succeeded with just put drains in the abdomen and thorax. And days 18, we have a nice X-ray, no leakage anymore. But of course, on the distal anastomosis between the graft and the lower pouch, which was quite short, maybe 1.5 centimeters, there was a stricture, and we started balloon dilatations. And we did on and on 15 sessions without needle machine, which we sometimes use. And then we decided that we have to do something. We can't make a resection because we may probably lose the graft on that situation. So we decided to order an Stent, and we tried to measure the length of the stricture. So I'm quite wary of any methods to measure a stricture closer than 2 centimeters. CT scan, MRI, contrast study, endoscopy are all inaccurate. When you go there and do an operation, it's completely different. 3 centimeters is like 1 centimeter, or 2 centimeters is suddenly 5 centimeters. So I find it very inaccurate. However, in the endoscopy, we measured that the stricture is 2 centimeters in the lower anastomosis. So we must keep in mind this is a neonatal boy, and that case half a year old. So the length of the jejunal graft actually is 5 centimeters, and the rest of the esophagus is 7 centimeters and say 2 centimeters to the stomach. So that may explain our slight failure, which we see. So we put this stent in place, and we follow the instructions. Everything went fine. There's the view from above and fill the lower pouch. But then you see that we reached the whole, both anastomosis, not only the lower one, which was our purpose. Okay, but we know that it's even better. The whole esophagus is now treated, and we see here that the 3 centimeter stent is actually something completely different when we see it in situ. I don't know what happened in that, but anyway, it bridges the whole graft and both anastomosis. So far so good, this was working fine, the baby started eating, not everything, but they rarely do because they have some kind of dislike for eating, and that's a stage of treatment. And we started to dilate after the stent slightly because it was necessary. All the granulations tissue we dilated and it went fine. And after 2 months, okay, there is some granulation tissue, but not that bad, and the baby is still eating. However, at this stage, we got some message. He was living in the northern Finland, and just the mother told that maybe the esophagus was too well open because he was vomiting more and more, just having reflux, like every patient with, or most of patients with esophageal atresia do. And the logical treatment is to keep the PPIs, proton pump inhibitors, and do a fundoplication. However, on this patient, we cannot do it because, or we're a little afraid of doing it because if you start to dissect the esophagus, you may cut actually the vascular pedicle, exactly, vascular pedicle, and then you're in trouble. And that's why we found the patient, we ordered him back to Helsinki, and we decided to do a feeding genostomy. And by the time the baby is walking, it will be usually all right. Then we can step back to the gastrostomy and then let the baby eat. However, he 2 weeks after that, I heard that the baby was died. He was taken for the bronchopneumonia in Elsewhere Hospital, and we were announced many weeks after that he was not more there. And we did not get any post-mortem. The family was of the religion which they didn't want it. And we do not know whether the death was because of our placement of the stent or just bronchopneumonia, which of course this patient with Down syndrome often get. I had a slide with conclusions, but I think I lost it somewhere. But I would conclude that you can use these stents probably with neonatal patients in the esophagus. However, like one of the presenters before me said, that you have to be in the same institution, preferably, and the same doctor who is taking care of it. I think that was a little bit too careless of us to not to take care of the reflux at the retrospective unit. Thank you very much.